we're really trying to promote health and wellness. And the way we're doing this is through weight loss, because being obese is associated with, decreased life expectancy, increased cancer risk, all these other comorbidities. And by decreasing those, we're actually making an impact that lasts. The goal of the Bariatric Surgery Program here at Texas Children's is to intervene in a way that we can help these patients, through weight loss, lead a healthier, longer life without all the problems that you experience from being overweight, all the medical problems, all the social problems, all these things that we can fix. It's only become an acceptable thing within the last few years to operate on adolescents for bariatric surgery. It's been an established thing in the adult population. It's always thought we should let these kids finish growing. It's too early to intervene. But now, with the new studies that have come out, the one that was most recently published in the New England Journal actually showed that the benefits when you intervene earlier are more durable and have a greater effect, especially on the comorbidities that we're starting to see in children younger than we had in the past. The traditional wisdom has always been diet and exercise. It's your fault if you're overweight, you eat too much, and you sit around all day. Unfortunately, diet and exercise, there's plenty of research out there that show that it's great if you want to look good in your bikini over the summer, but if you really want lasting, durable results, it just isn't the answer, especially when you get into the people that are morbidly obese. A good diet regimen is going to usually on average lose about 0.5 to even the most dramatic, maybe 2 pounds a week. When you're talking about trying to lose 200 pounds or 300 pounds, as in some of our patients, we're talking 4 or 5 years of strict dieting and exercise to see any benefit of this. Now you contrast this to bariatric surgery, where we're looking at about 30% off of your BMI or 70% of your excess weight within the first year. That's a significant change. And that's more durable as well, as we're seeing very similar numbers out in 5 years. Over 20% of adolescents in the United States right now are overweight and approaching the obese category. This number is going up every year. Things that we used to see in patients in their 30s and 40s or even 40s and 50s are now showing up in my clinic in teenagers. We're talking about things like diabetes, high blood pressure. I've got kids that need knee replacements, hip replacements, obstructive sleep apnea. Very common in this patient population. Everybody that comes in gets a sleep study. A lot of our patients are referred by the pediatric gynecologist for PCOS. So they're having problems with facial hair, body hair, painful, irregular cycles, not able to ovulate appropriately. These things will clear up when the weight comes off. It's another benefit of having a surgery. We're trying to get them up and active and back into life. It's a minimum 6-month program. It's a multidisciplinary program, which means we have a lot of different specialists looking at every aspect of this child's health before we consider them for surgery. Typically, the first visit's the big one. You're going to meet with me or Dr. Rodriguez, the surgeon. You're going to meet with the dietitian. We have a social worker available to talk to you, and usually that's the longer visit. We order a ton of labs. We do a lot of studies. We do x-rays. We do ultrasounds, and we're looking for everything that could possibly be wrong related to obesity. After that, there are monthly visits. The monthly visit primarily is with a dietitian, and we have 2 different support groups. We've got one more focuses on eating habits and exercise, and we've got the other that's with our psychologist that actually is a binge eating support group. You'll also check in with my PA, who's going to work with you on some of your homework assignments and check out how you're doing, follow up with your lab results. And we're going to do things like keep food logs. We're going to evaluate your eating habits, because what we want to do over the course of this, we've already said that diet and exercise don't work, right? So we're not going to put you on a crash diet that works great for 2 months and then you mess up and you start eating again and gain all your weight back, which happens to me every 2 or 3 months too. It's just the way it is. What we're going to do is try to make small changes. We don't want to put you on a diet that's going to make life not worth living. We just want to figure out there's areas where we can make small adjustments. Then in the end, they're really going to make a difference after surgery. If you do this now, you might lose a couple pounds. You might just not gain as much as you were before. But that same change after surgery is going to have a much more dramatic impact as your metabolism changes, as your eating habits change after surgery, as your tastes change after surgery, and it's going to really result in much more durable weight loss. That's a lot of what these homework assignments are part of, which is, do your food log. Become aware of what you're eating so you can make good decisions. Same with exercise. I don't expect everybody to get up at 4:30 in the morning and run on a treadmill for an hour. But if I can get you moving 3 days a week, I don't care what you're doing. You can be dancing in your room with your earbuds in. You can be walking around the mall. As long as you're not walking to the food court, it's a win, right? You got a dog, somebody needs to walk the dog. It doesn't even have to be the same thing every day. And if it's something that's fun, something that we can find that you enjoy doing, then that's a great start, because you get into that habit. It's not forcing yourself to do something that's not fun. As things go along, we have to make a decision as we approach that 6-month mark. First of all, is it something that this person wants to do? Are they committed to it? What I don't want to do is do an operation on somebody that's going to alter their anatomy and have them not be compliant with the plan afterwards and eliminate all the positive results we get. The surgery is not a magic wand, so you have to take an active role. Once I put that last stitch in the operating room, the only thing I can do to help you out is be a cheerleader. Okay, because I've done everything that we can do. We've equipped you with all those good lifestyle habits, and we've done the surgery. If you go back to eating the same things, if you force yourself to eat beyond what your stomach can take and stretch it out, over the course of a couple of years, it'll be like you never had the surgery at all. We don't want that to happen. So the only way we have to have any insight into that is how you do with the homework assignments. If we ask you to log your food and exercise, and you come to your appointment and you say, you know, I didn't do it, I didn't log it, I don't know, I just didn't have time, or I didn't feel like it, that's kind of telling me you're really not going to do what we ask. If you can't do it before surgery, you're probably not going to do it afterwards. If you're coming in and you're saying, oh yeah, I'm eating nothing but carrots and broccoli and I'm running 17 miles a day, but you gain 25 pounds, you're lying to me. And if you're lying to me, I don't want to do surgery on you, because you'll lie to me after surgery. I want those kids that are actually willing to make an effort on their own behalf to actually qualify for the surgery. You stick with the plan, you eat what you're supposed to eat, you do what you're supposed to do from an exercise standpoint, which isn't a lot. That combined with the surgery, you'll have fantastic results. If you don't, like I said, it's not a magic wand. The weight just doesn't disappear. It actually requires some effort. Currently, we offer 2 procedures at Texas Children's for bariatric surgery. We offer the Roux-en-Y gastric bypass and the sleeve gastrectomy. Both of these are laparoscopic procedures, which minimally invasive, using small incisions and cameras. The Roux-en-Y gastric bypass, that's been around the longest, and there's the most data on that. The way this works is we actually use a stapler and we turn your stomach, the top part, into a pouch. That pouch is about the size of a boiled egg. So we say that this is a restrictive procedure because it restricts how much you can eat. We then go downstream in the intestines and divide the intestines, and we take the lower end and we attach it to that pouch. And that way we're bypassing all that end that's still attached to what's left of your stomach, your liver, and your pancreas, which we then tie in, and that's the Y part, downstream. So because we're bypassing all that part of the intestine, you don't get to absorb nutrients or vitamins or minerals there, which is supposed to also contribute to weight loss. But it does make you dependent upon vitamin supplementation for the rest of your life. There are all sorts of horrible metabolic complications that can happen if you're not compliant. And then we start getting into problems. There are also a certain number of complications that are associated with the Roux-en-Y gastric bypass. This has to do with stricture formation, at the area where we sew the intestines to the stomach there, ulcer formation there. Anybody that's ever smoked can't get this operation because it increases your risk of ulcers so high. You can get internal hernias. There can be problems with malabsorption. I mean, these are all things we have to consider in the post-operative period. The second operation is the sleeve gastrectomy, and this is the newer operation. And right now, about 85 to 90% of the surgeries done in the United States, and particularly in adolescents, are the sleeve gastrectomy. And the reason for this is what we're doing when we do the gastrectomy is we're just taking off the outside of the stomach, and the part of the stomach that's left is about the size and shape of a banana. We take out that part of the stomach completely, so it's a restrictive procedure, but we don't do any bypassing. Now, one of the advantages of this is that part of the stomach that we take out actually secretes a hormone called ghrelin, which makes you hungry. So with that part of the stomach out of your body, which doesn't happen with the bypass, you actually have less physiological hunger than you would if we left it in. So that assists in the weight loss. Now, it's important at this point to differentiate between physiologic hunger and psychological hunger because they're both aspects of hunger. If you ask me right now, am I hungry? I'd tell you no, I had lunch, I'm fine, I'm good. But if you bring a cart in of delicious things and a steak that's wafting up this, I'll tell you right now I'm hungry and I want to eat it, my mouth will water. So don't expect that to be affected. It will affect, though, that desire to eat when you're not thinking about it. You won't have those hunger pangs. Because we don't bypass, We don't have to worry about vitamin supplementation for the rest of your life. In addition, we don't have to worry about strictures, we don't have to worry about hernias. The complication rate is significantly lower. Now, what we found with the recent research is that the efficacy or how well that the sleeve works compared to the bypass, they're very similar, within a percentage point or two of each other. With the sleeve, because of the way we do it, if in the future there were a reason to require a second operation, say you did have really bad reflux and we weren't able to control it with medications, we could always convert it into a bypass. The opposite is not true. We really can't convert the bypass into anything else. All the procedures we do laparoscopically, and the approaches are very similar. So we're using 5mm instruments with the exception of the stapler. So if we're talking about the sleeve gastrectomy, the only reason I need an incision larger than 5mm is we have to take that part of the stomach out. So what you'll have is 4 small incisions that are 5mm in length, and then 1 larger incision. That's, if you were to look at it, it's probably about 1.5 inches, and that's where we take that stomach out of. Post-operative course is different for everybody. People have different pain thresholds. People are better about drinking and moving than, some are better than others. But typically our patients are going home the day after surgery. What we're looking for is for them to meet their fluid intake goals and to be up moving around and their pain to be well controlled. If that takes a day, usually those kids are out by dinner time the next day. If it takes longer, we're not going to kick you out, we'll keep you longer. However long it takes to get you to where you're ready to go home. One of the biggest complications from both parts of the surgery is dehydration. You have to keep up your fluid intake, and that's one of the goals we have before you leave the hospital, is a certain volume. It's actually 64 ounces of fluid in 24 hours that we want you to be taking before we can let you go. If you don't keep up with that and you get dehydrated, it makes you nauseated. When you get nauseated, it's harder to drink, you get more dehydrated, you start vomiting, and there are a lot of complications associated with that. Repeated vomiting that are going to require rehospitalization, rehydration, and then we start all over again. And we really don't want that to happen. For the initial phase, it's not a lot of fun. You're on this liquid diet for 2 weeks, which gets a little monotonous. It is difficult to drink at first, just because number one, you can't take the volumes that you think you're going to be able to take or that you're required. It's very difficult. You have to drink every 15 minutes. If you're going back to school, we're going to give you a note so that you can drink at school. It's very important to keep up with your fluid intake. We'll go to full liquids, but you're going to be on some form of bariatric full liquid diet for the first month. So afterwards, a lot of those foods that you were craving before surgery are going to make you ill to even think about, which is good in a way because it's going to help you set new habits and get a taste for new types of foods that are hopefully the healthy ones we've been working up to this whole time. Typical weight loss that we're seeing is about 1 pound a day in the beginning. Now, we're not really looking at the scale. We're not trying to make everybody hit those marks. We encourage you not to weigh yourself every day at home. It's not a big deal. We want you to be healthy and to lose weight in a responsible fashion. But usually if you're sticking with the plan, post-operatively, your first post-op visit is at 2 weeks. This is just a quick post-surgical check to make sure you're healing well and that there's no problems. On average, we're seeing 13 to 15 pounds of weight loss. And that continues out through the first month. It's very common for the patients that have lost 30 pounds or more in the first month. We're going to see the maximum weight loss at about a year out. On average, it's about 30 to 32% of your BMI off by the end of the first year, or 70 to 75% of your excess body weight. Another huge advantage of getting this done when you're younger, the reason kids don't have wrinkles is their collagen works so much better. So that skin may be stretched out, but it's going to recover significantly after surgery. What we want to see is that a year or 2 out, when your weight has kind of stabilized where it's going to be and your skin has had a chance to recover, we'll reassess at that time. The majority of patients don't require any intervention at all. It kind of tightens up and they don't have those big flaps of skin that you would see in an older patient. But for those that do, that maybe started out bigger, we do have plastic surgery available here who are capable of performing that operation and taking care of that. Initial follow-up is going to be your 2-week follow-up for your post-op check. We'll then see you at 1 month, 3 months, 6 months, and then annually for the next 4 years. We follow all our patients for a minimum of 4 years out. At 4 years, we don't kick you out and say we'll never see you again. If you have problems or questions, whatever, we're happy to see you at any time. Keep coming back as long as you want. We'll keep taking care of you even when you become an adult. The opportunity to work with these patients and help them achieve their goals of weight loss and help them deal with the medical problems that come from being heavy in a durable way that's going to be lifelong and just have a great impact on both their life expectancy and their health is an awesome opportunity. And I'm really happy to be a part of a program like this.